Hi, welcome back to IU Radiology Case of the Day. My name is Nick Kuntz, and I'm a neuroradiologist and head and neck imager at Indiana University School of Medicine, and I'm back with another interesting spine imaging case of the day. As always, I'd like to start out by stating that all of the content found as part of this lecture has been completely de-identified in order to protect patient privacy. So the history in this case is an adult who presented with chronic back pain, and it's a younger adult, but they've been having back pain for several years, certainly as far back as they can remember. So I have 4 images for you to take a look at. The first 2 images on the left are coronal non-contrast CT images in bone algorithm reconstruction. The third image is a sagittal T2 weighted image, and then the fourth image, the image on the right, is a coronal non-contrast CT image through the upper abdomen. So take a look at the findings, or the images we have here. Keep in mind that history. This is a younger adult that has many years of back pain, and try to piece it all together. Now there's some important clinical history that I'm not telling you. I want to see if you can piece it together and figure out what that might be. Okay, so what are the findings? What's your differential diagnosis? And then putting it all together, what's the most likely diagnosis here? What underlying medical issue does this patient have? All right, let's take a look. First image is a coronal non-contrast bone CT image, and where this yellow arrow is pointing along the right lateral side of this disc space, we can see a thin lateral syndesma phyte at this mid-lumbar level. And if you look carefully, you can also see multiple pelvic enthesophytes, these little protuberance of bone coming off where these muscles insert at. So you can see right where those yellow arrows, those enthesophytes, can be helpful clues that maybe this patient has something rheumatologic going on. Next, as we go a few slices back on this coronal non-contrast bone CT, you can see there's just this little bit of sclerosis of the sacroiliac joints. And if you look closely, right where sort of the tips of the arrows are, you can see there's a bit of a smudged appearance of that subcortical iliac bone, especially on the right, but you can see it also on the left. We've sort of lost that sharpness. Almost looks like someone took an eraser to some graphite pencil and smudged it just a little bit. We're losing that sharp cortex. And the cortex is a little bit irregular overlying this, again, more so on the right than on the left. So this appearance sort of has the look of a mild sacroiliitis. So piece that together, a mild sacroiliitis. Maybe they've got a little can't even speak, enthesopathy. We'll fix that in post-production. So now we look at our coronal T2 weighted image. You can see that we've got this abnormal appearance of the L4 and L5 discovertebral unit. And so we have this sort of little bit of in-plate irregularity, but we have this band-like or linear bright T2 signal intensity along the in-plate. So this patient had a so-called Anderson lesion. They've had this sort of this inflammatory response going on at the discovertebral unit. And importantly, there's no epidural or paraspinal abscess that we can see on this imaging. And so that's sort of a sterile, non-infectious spondylodiscitis, this so-called Anderson lesion. So that hopefully gives away the answer as to what we're looking for here. But as we move on to our coronal non-contrast CT through the upper abdomen, we can see there's this abnormal appearance of the transverse colon segmentally, where the wall is thickened. You can see more proximal and even more distal. The bowel wall is thin, but here in this transverse segment, bowel wall is thickened. It's stenotic, so segmentally the whole caliber is narrowed, and it has this featureless appearance of the mucosa. Now, I know this is a non-contrast CT, but you can actually infer some physiologic information about this and say that this patient also has some adjacent mesenteric hyperemia, because we can see all these engorged vessels outlined nicely in this mesenteric fat. So they have mesenteric hyperemia, this so-called comb sign of vascular engorgement. So put this all together, this patient who has sort of this inflammatory spondyloarthropathy look in their spine and in their pelvis, and then they also have this appearance of their colon. What's this patient have? So this is a case of enteropathic spondyloarthropathy, or Crohn's disease. And so this is a seronegative inflammatory arthritis that is most commonly seen in the setting of inflammatory bowel disease, either ulcerative colitis or Crohn's disease. But you can also see it in the setting of Whipple, celiac disease, even infectious enteritis. Sometimes we see it in the setting of prior GI bypass surgery, and it's been reported in parasitic infections as well. But importantly, these patients with enteropathic spondyloarthropathy have both a peripheral and axial arthritis. And so this will commonly involve the spine and even the sacroiliac joints, as this case pointed out. And these can be challenging cases because the imaging appearance can look a lot like ankylosing spondylitis. So it sort of goes into this bit of a nebulous trash can inflammatory spondyloarthropathy diagnosis, and then you need to dig in, look at other clinical factors, look at other imaging studies, and try to figure out how you can add some specificity to which inflammatory spondyloarthritis or inflammatory spondyloarthropathy the patient might have. So with enteropathic spondyloarthropathy, some of the common findings to know about. Well, first of all, on CT or even on x-rays, look for reparative sclerosis at the vertebral body corners, the so-called shiny corners, the reparative sclerosis of bone that you get from the healing erosions that are associated with this inflammatory process. You can get some squaring of the vertebral bodies. You may see ossification of the spinal ligaments, as well as ankylosis across the vertebral discs. We saw that lateral syndesma fight where it was starting to put down some productive calcification and starting to ankylose across. And then also, as this case nicely showed, you may see those features of sacroiliitis as well. MRI can be helpful because it sort of ups the sensitivity for looking at more of the acute inflammatory response. And you can see these small inflammatory erosions at the vertebral corners, so-called Romanus lesions that are the sort of the precursor to the shiny corners. And they can also have, as this patient did, sterile non-infectious spondylodiscitis. If they had a fever, they had paraspinal phlegmon or abscess, sure, it would look like discitis osteomyelitis, but this is a sterile spondylodiscitis that these patients have. So there's a paper that I think all the trainees out there really ought to take a peek at. This is one of the important ACR appropriateness criteria, and this is looking at what do you need to do in terms of imaging patients that have chronic back pain and there's a suspected component of sacroiliitis or one of these spondyloarthropathies. So nice paper to take a look at, especially if you're reading MSK or neuroradiology studies. Okay, so let's wrap this up. This again was a case of enteropathic spondyloarthropathy related to Crohn's disease. And the things to look for are features of sacroiliitis and enthesopathy that sort of tells you, hey, we're dealing with something in this inflammatory spondy category. And you may see things like those lateral syndesma fights, as well as the spondylodiscitis. And when you look and see this spondylodiscitis, you need to look and say, hey, does this patient have an abscess or phlegmon in the surrounding soft tissues, or does it look pretty clean? In this case, it's a sterile spondylodiscitis, the so-called Anderson lesion. Now, there are some pitfalls to know about, and I alluded to this already. These seronegative spondyloarthropathies all look quite similar, and you're not always going to be able to give a specific diagnosis, and that's okay. It may be more important to get the clinicians thinking about that in terms of this patient might fall into that camp, and then they can begin a rheumatologic workup and try to figure out whether or not the patient in fact does have a seronegative spondyloarthropathy. But then I'd also stress it's important to go digging outside of the spine. Oftentimes the answer to this question is going to be found in the patient's jacket, but you're going to have to dig through different imaging studies that may be outside of your subspecialty. MSK studies, belly CTs. You can find the answer to these not infrequently by looking a little bit deeper and trying to piece all these puzzle pieces together to figure out what the most likely diagnosis is. Well, as always, thanks for tuning into IU Radiology Case of the Day. I would invite you to check out our complete collection of Case of the Day materials that can be found at radtf.iuhealth.org/COTD. And you can always follow along on Twitter under my handle, which is @NAKuntz. Thank you so much.